I have no disclosures. This is the interesting case or interesting technique section. The title is Cold Leg, no lytics, no problem. This is basically an endovascular arterial fempop declot without the use of lytics. I'm going to show two cases that present in different ways. First case is a 58-year-old male status post fempop bypass graft on the left ×2, and he presented with left lower extremity pain for 2 months. This is the initial angiogram. It demonstrates occlusion of the native SFA, and you see the nubbins of the two fempop bypass grafts that are occluded proximally. Further down, the angiogram demonstrates reconstitution above the knee on the left, and there's patent 3-vessel runoff bilaterally. So what we did was got a atraumatic wire through the proximal fempop bypass graft, got a 4 French catheter intraluminally, and proved that we were still within the vessel. And then we placed a guard dog, which is a balloon wire, an 035 wire. It's made by Medrad Passes, and we deployed this and angiojetted the entire fempop. This is the guard dog's CO2 system. The images after 2 passes demonstrate proximally there was no significant residual stenosis. There is a Copert lesion here. Mid portion is completely wide open, and then distally is also wide open with another Copert lesion. So we angioplasty the proximal and distal ends, and then it showed some residual stenosis, so we placed a bare metal stent distally, and the proximal lesion, which was resistant to angioplasty, we also stented, which shows no significant residual stenosis. And the final images demonstrate widely patent bypass graft, and we didn't trash or send any embolic phenomena down the leg remaining. So the entire case was done without lytics, and the impression is basically complete restoration of a 2-month occluded fempop bypass graft with angiojet and guard dog alone, no lytics involved. The patient was actually discharged the same day. Second case, a companion case, 54-year-old patient, status post SFA stenosis on the left. They were treated with stent placement back in 07. About 2 months later, they presented with occlusion of the prior SFA stent. You can see the stent in place and the area of occlusion in the mid to distal SFA. Distally, the patient had reconstitution and patent 3-vessel runoff. The patient was then subsequently treated with TPA infusion. Infusion catheter was placed within the area of occlusion. Follow-up demonstrates decent results. However, there was still some residual clot, and the patient was then angioplastic and stented furthermore. And distally, the patient still had 3-vessel runoff. Same patient presented about 2 years later with severe claudication of left lower extremity. And the initial angiogram demonstrates occlusion of that same area that was previously stented and treated. And distally, there was still at least 2-vessel runoff that you can see here in the left lower extremity. The lesion was then crossed with an 035 wire and a 4 French catheter, demonstrating intraluminal, and then the guard dog came back and was over the guard dog occlusion balloon wire, embolic protection, angiojet, stent placement, and angioplasty. And these are, there's some stents, and then the angiogram afterwards demonstrates no significant residual stenosis or clot, and again, 2-vessel runoff unchanged. Impression on this is, again, complete restoration of the occluded left native SFA with angiojet, stent placement, PTA with the guard dog alone, no lytics involved. That patient was also discharged on the same day. So in conclusion, the use of guard dog as an embolic protection arterial declot procedures can eliminate or reduce the time of thrombolytics. Eliminating lytics during these procedures can significantly decrease healthcare costs, cost of TPA or ICU rooms. TPA in our hospital is about $2,400 a bag. If you drip these patients for 1 to 2 days, you're looking at maybe about $5,000, and ICU rooms are anywhere from $4,000 to $5,000 a day. So that's probably about a savings of possibly $10,000 there. But most importantly, though, removing lytics can lower complications associated with this procedure, such as groin hematomas, GI bleeds, or the dreaded cerebral hemorrhage. Any questions?
Right.
Yeah, I guess, I don't need a microphone. That was very nice, but could you tell us a little bit more about what this guard dog is? A little more descriptive, exactly.
The guard dog is essentially, it's an 035 wire. It's about 260 or 280 centimeters of working length. At the end of it is a very flexible, soft atraumatic tip. And then there's a canister, which I showed that quick picture, but you can inject CO2 into the balloon, and it works as an embolic. And you can either put lytics behind it, you can pulse spray it, you can do angiojet, or you can actually perform your angioplasties and or stent placement with the balloon deployed so that you're not throwing thrombus or
So it basically includes the distal outflow.
Exactly.
Jerry, I think that this was a great example of using this device, which I think is very beneficial because ideally you want to get rid of the clot by lytics or by thrombectomy device while the clot is still inside the graft. If you don't use this type of device and you use a thrombectomy device like the angiojet, most likely you will have part of the clots moving downstream into smaller vessels, tibial vessels, and sometimes those respond or sometimes they don't respond to lytic therapy and they are more difficult to touch. So I think that was a great case. Thank you.